Welcome back to Cath Lab Outreach. My name's Scott. This episode is intended more for folks who will take care of patients with a heart cath. So let's talk about access site and site bleeding. So your most common access site for a left heart cath is your right radial artery. A lot of that's just because of convention, how the room is set up. The patients or the doctors, most doctors are right-handed, so everything's on that side for them to be able to advance things up the right arm and go up and take pictures. The left arm is another option that can cross over. Some cases you can go to the other side and do the whole case from that side, but most folks will cross over now and have that left arm lay where the left groin is and get the same access there. So when you talk about access sites, some of the ones that you'll see here is the right radial that we talked about. You'll have ulnar also. Some patients, I think I'm one of those patients, who just has a larger ulnar artery at that site than the radial, and that's a perfectly acceptable option. The difference in choosing right and left is the patient's artery large enough for that, have they had other things that complicate that site, but primary from a cardiac reason, it's the Lima graft. The left internal mammary artery comes off the left subclavian. That's a very common site for surgeons to unplug it from the mediastinum and then plug it into the LAD or one of the other vessels. So if you're using that site, it can be very difficult to go from a right radial artery, come into the aortic arch, and then go back up and get out to the left subclavian artery. So a lot of times those patients, they'll just switch over and use a left radial approach if possible. Other times we've also used the brachial vein for right heart cath access, and that's an easy site there too. The nice things about using the radial or the brachial is the patient can sit up immediately following the case. If you go femoral, that's not the case, there's usually less chance for bleeding. You think about that radial artery; it's observable and easily compressible. No one should die from a radial artery site bleed. So if you monitor that site, you can make sure it's not bleeding. And just like all bleeds, you hold pressure. If you see bleeding, if you see a hematoma growing from that site, pressure is the key. And we'll talk more about that. Groin access can be a little more complicated. It was the mainstay for heart caths for decades. Now it's kind of become the high risk, low volume evolution for heart caths. The advent of ultrasound and that being the standard of care for getting access significantly decreases chances, but you also have patient compliance if they sit up in bed afterwards with the sheath in, or sit up too early when they're not being monitored, or if they're still feeling the effects of sedation. Those are all possibilities. But let's talk about anatomy first. Going in the legs, or the femoral vein and artery, you can always remember your location by the mnemonic NAVY, nerve, artery, vein. The legs make a Y, and then coming laterally to medial on the other side, nerve, artery, vein. The legs make a Y. So that's an easy mnemonic to use to remember that. So if you have two sheaths in the groin, the one that's medial should be the vein. The one that's lateral should be the artery. Why do we pick where we pick for access? Well, this site here gives you a good example. What we want to be is above the bifurcation. That's a bifurcation in the artery of the superficial femoral artery and the profunda. You always think about the profunda goes profoundly deep in the leg. That's where that comes from. And then you also have the inguinal ligament. A lot of times they'll take an x-ray and put a piece of metal, a hemostat or something above there to mark the femoral head. And what they want to do is be above the middle of the femoral head and not go above that site. Above that site, that inguinal ligament kind of defines the retroperitoneal space. So if you have bleeding from that area, if you have a high stick above that inguinal ligament, then those patients can actually get retroperitoneal bleeds, things that can hold a lot of blood before they become evident. This little oblique view here at the bottom right gives us an example, a little understanding of why we pick where we pick. We want to be above the bifurcation. That makes putting in closure devices safer. You're not compromising two different, the bifurcation in two different vessels. But here, the arteries are very deep. They surface on this plateau of over the bone, which gives you an opportunity to hold pressure there when you need to. And then it dives back down into the abdomen. So that little shelf there gives you a perfect opportunity to hold pressure, should that be the case. And that often is the case. Some patients don't do well with closure devices. They are not candidates for closure devices. So that you can't put the plug in. That's uh, often commented on just to make it an easier education. So you have to hold pressure over that site. Too high and too low can make that quite difficult. So indications of the femoral bleeding, obviously one, hematoma. I've seen some very large hematomas where it takes up over, that whole half of the patient's body in that area. A new low back pain. And that can be hard because a lot of your heart cath patients, especially ones who've been around through CABG and multiple heart caths, they have back pain all the time. So is this a new type of back pain? Is this, when you have back pain at home, is this similar to what you feel there? A hypotension would be a late sign. We would want to see tachycardia if we're actually heading toward a shock state from hypovolemia. Sometimes you can get a vagal response, and the vagal responses can be very dramatic. They really get your attention, and they are disproportionate to what's going on. That vagus nerve is hit, they get pale, diaphoretic, they pass out. All the things that go along with that, and really it's just that vagus nerve being overexcited, knocking out that heart rate. So a vagal response could come from you holding pressure, but also it can come from the swelling and the pressure inside of that area. And then you also have loss of distal pulses, which would be a late sign and a bad sign. So when you talk about holding manual pressure, what if you are up on the floor? What if you're in the unit and now we see this hematoma starting? A lot of places will call the cath lab, and cath lab does hold pressure all the time. That's something they're very familiar with. But until they get there, until other people come, holding pressure is your primary thing. That's all they're going to do. That's all you do for any bleed is hold pressure. So we're going to hold pressure. If you think about how the blood flows, what we see on the surface is we're going to see a skin nick, and that needle is going to be heading superior. It's going to find the artery and have the arteriotomy where it actually cuts into the artery. Will be just north of the skin nick of the site there. What we actually want to do is we want to hold pressure above that. One of the guys that trained me would think about putting his the most distal finger to the patient, heading toward the foot, put that over the access site. The middle finger would be over where the arteriotomy actually is, and then that last finger the third finger up would mark where he'd want to hold pressure. That's a good way to do it. If you put your first finger there, your second finger would mark your arteriotomy, and then the next finger above that would actually mark where you want to hold pressure. One of the good cheat ways to know that you have good pressure, especially with different body habitus, it can be very challenging to know, do I have good control over this? Early on, when that sheath comes out, you can feel the sheath in there, and as it comes out, you can feel that pulsing. If the hematoma has developed, that can be quite challenging to find that. But a pulse oximeter on the toe of that affected leg, when you hold good pressure, you can obliterate that waveform. And then when you let up a little bit, that waveform is restored. So you're at the right site. You have good control. Fem stop is kind of the ultimate stopping for that, short of going to surgery or vascular surgery for that site. But a fem stop has a star area in the plastic that goes over top of the arteriotomy site, just a little bit north of that, so it can hold pressure, like we talked about where you want to hold pressure. This has a strap that will go around the waist and will come back up through these areas. You pull those strap tight, and then you can actually inflate your cuff here, your bulb, and get pressure. Initially, per FemStop's instructions, you want to be 10 to 20 millimeters of mercury above systolic initially to get hemostasis, but for no more than 3 minutes. And then you want to walk that back down until you have no bleeding, but a palpable pulse distal to that. And a lot of times that pulse oximeter can be that help for that as well. Talk about radial artery bleeding. A lot of times that's just going to be a simple hematoma at the site. It can move up the forearm and make that more complicated to know, is this something different or is this bleeding from one site? One of your big complications that I've seen is a small, instead of the wire traveling up the radial artery, it finds its way into a small branch, and you can actually have a perforation there. And now what you're heading toward is compartment syndrome. Remember, the hallmark for compartment syndrome is disproportionate pain. Pain just at that site, and then when you touch that, and that pain is just through the roof. That's a disproportionate amount of pain. All you had was a needle puncture here. It may be sore, but super painful should not be the definition. So if a forearm starts to swell a lot and that pain is just going through the roof, then that's a good sign for compartment syndrome, and that needs followed up promptly. Once again, hold pressure above the site. So you think about where your skin nick will be, your skin puncture will be, and that won't be quite as far away from the arteriotomy as it would be on the femoral, especially if the person in the femoral was a large person. But your wrist typically pretty skinny, and you get access through that. It's not far above that at all that you get the arteriotomy, and then above that is where you'd want to hold pressure. And most folks, most hospitals can take hemobands throughout the hospital, and there's different kinds. There's VAS band, there's TR bands, there's a couple of other ones out there. But one of the things that's important for this, it's no problem to crank this thing up and stop all blood flow, but that's not what we want. We want patent hemostasis, and that means that we have a pulse distal to the site on the same artery that was punctured with no bleeding. And that's patent hemostasis, and that's your goal when you inflate this. You should be able to palpate a pulse distal to the band. Sometimes you can look through the band and see the plastic pulsing and the light hitting that plastic and make it a little bit easier to see. But patent hemostasis is our goal. That way the hand stays perfused, the body is still able to deliver clotting material to that site, and that patient has a less chance of receiving a right artery or arterial occlusion after that. All right, that's it. I hope that was helpful.